I'm Katie, and I'm here today to talk to you about lip and tongue ties. First, this video is meant to help parents identify possible red tags that might mean that they need to have their baby, toddler, or even an adult evaluated to see if they have a lip or a tongue tie. So, a lip tie is a membrane, residual tissue left over from fetal development that was meant to receive but didn't. And a lip tie is between the underside of your lip and your upper gums. A tongue tie, or a lingual frenulum, is under your tongue, between your tongue and the floor of your mouth. Now, tongue ties come in 4 basic grades. A lot of people that'll get diagnosed with a type 4 tongue tie think it's worse, the worst possible one. But tongue tie numbers are location. They're like the zip code of your tongue tie, not the severity. 4 being clear to the tip of your tongue, a 1 or a posterior tie all the way back underneath the tissue behind your salivary glands. So, a tongue tie isn't just a membrane. A presence of a membrane alone isn't a diagnosis. It has to be restrictive. It has to block the tongue from its normal motion. And that's what causes the problem with breastfeeding. A baby who has a tongue tie may not be able to extend their tongue over their gums and still be able to suck, swallow, and breathe without choking, or to have a good range of motion for their tongue. One of the things you might notice in an infant is they almost look like they're chewing on your breast instead of their tongue underneath, really massaging and working for a letdown. Moms with the tongue-tied babies frequently have a lot of pain, and when that baby comes off of the breast, you'll notice that the tip of their nipple looks more like a smashed thumb. It's got a point to it, or a crease. We call it a compression stripe. And it can even make an open wound. And it won't usually go away and heal all the way while you're nursing, even if you repeatedly put the baby on nice and deep. They pull shallow, partly because they're scared of choking, because they can't control the flow and protect their airway, which is also why tongue-tied babies frequently have a lot of gas and reflux from trying to gulp from that lack of range of motion. Also, because your tongue shapes your palate, and that baby's tongue hasn't been able to nicely press on their palate, they may have a really high palate or a really steep arch to it. And that can make kind of a clicking sound when the flow is really fast. And if you watch the baby's jaw while they're nursing and you're having a letdown and the milk is fast, you'll see their tongue kind of snap down. You see it? And you'll see it. And that can be another red flag that the baby has a restriction. So, if I was going to go examine a baby's mouth, I really like a tool that you can get online for free called the Hazel Baker Assessment Tool for Lingual Frenulum Function. Big long word. And it's available online for free. You can get it from Allison Hazel Baker's site. And it goes over step by step, really clearly, really easy to understand instructions and classing so that you can rate the baby's function. Or you can bring it with you to your pediatrician if you want to have them examine it, maybe get an idea of what's going on. And part of what I like about it, the very first thing it talks about is the appearance of the baby's tongue. So, it's my pretend baby here. Normally I'd have a baby laying in front of me and I'd have my headlamp on so I could clearly see, but that doesn't work for this video. So, if you're looking at the baby's tongue, it should have kind of a nice, little bit of a pointed, roundish tongue, and the baby should be able to stick it out over the gums. If you notice that the baby's tongue has a blunt edge to it, like whoop, or if it has a bit of a V or a cleft, and sometimes with class 4 tongue ties, you can even see when the baby's mouth is just barely open, the membrane underneath. And that's a really big red flag. We call those across the room ties because you can see it across the room. The next thing you want to look at is the elasticity of the baby's tongue, of the baby's membrane. So if the baby was laying in front of me, I would use my pinky fingers with gloves and I would lift up the baby's tongue and I would feel, does it easily move all the way above the midline? Can I move the tongue around? Or if I get my fingers under there, is it pretty rigid and restricted? And that would tell me that that membrane is not very elastic. Now, if that baby does have a visible membrane underneath there, we would describe it depending on how close it comes to the tip of the tongue. And we would do that by, if it is greater than 1 centimeter in length, it would come almost to the tip of the baby's tongue. If it's 1 centimeter, pretty much about halfway to 3/4 of the way, but it's definitely a membrane in front of the salivary glands. If it's less than 1 centimeter, then it may be just a little bit visible, but when you go to lift up, you'll see kind of a smooth, shiny, and taut membrane under the skin. You can't really see them themselves. What you can see is how they don't allow the tongue to move. And that would give you a hint that they have a posterior tongue tie, which is the hardest for people to diagnose. And unless you have that baby facing this way on your lap with a headlight and you lift up their tongue, it's really hard to see a posterior tie. The next thing you want to do is you want to look at if there is a membrane. Where does that membrane attach on the baby's lower gums? Some of them will come all the way forward and connect to the top of the baby's inside lower jaw. Sometimes they'll even have like little webbed pieces down, look like a little tiny Eiffel Tower. Now, after that, you want to, I have the baby suck on my gloved finger, either pinky or index, and I want to feel, does that baby cup my finger well, the way you'd want them to cup the breast, or is their tongue appear kind of flat, or does it kind of buckle, or are they not able to really extend it and cup your finger? Then you want to see peristalsis, which is a fancy word for the motion. The baby's tongue should move in a motion from tip to back in a nice little wave, and that's what really helps pull the milk out of the breast. Babies don't use just suction the way a pump does. The baby uses the motion of their tongue to trigger that letdown and really get a good volume of milk. If a baby is tongue-tied, their tongue may just kind of scissor back and forth, and moms will feel that as kind of a scraping on the underside of their nipple, or a baby may just piston their tongue up and smash the nipple. And that's where you get that smashed thumb-looking shape and a lot of nipple damage and pain. And it also restricts how much milk the baby can get out. Like when you're pinching the end of a garden hose, you don't get nearly as much water out of it. Same with the nipple. And it's also a fact that a lot of tongue-tied babies have short feeds and they get tired before they're really full. So they'll tend to get a lot of the foremilk but not really be able to sustain a nice long nursing where they're awake and active with lots of swallowing and getting to that hind milk. So they tend to want to eat very frequently, but they fall asleep before they're full. Babies need to be able to lateralize or move their tongue from side to side. So you'll touch the baby's gums with your glove finger and they'll move it and they'll chase it. It's kind of fun to do. And they will chase your finger. And you can see how well does that baby move their tongue side to side, which is important for nursing, but it's also very important for solid food. Imagine trying to eat food if you can't move a bolus of food around your mouth. You're not going to do a very good job. Okay. So when you're in there and you lift up that baby's tongue, you want to see if only the tip of the tongue lifts or if you can move the whole body of the tongue, if one side moves more than the other, or if that baby's tongue is so tightly tethered that you can't move it much at all. That's going to be a very restricted tongue, and that baby's not going to be able to do a good job of nursing. You also want to see, and you can do this with a pacifier or the breast or even with your finger, have that baby sucking on your glove finger. You should be able to see their tongue over their gums if you pull back their lip. You should be able to see that cute little tongue under there. If you can't, then that tells you the baby isn't able to extend it. A tongue tie can make it to where when the baby, if you touch down here and they go to extend their tongue, it either bunches and humps up, or if you touch their upper ones to get them to lift it, only the tip will lift and the back of their tongue stays down. That tells you that they have a restriction in the back of their tongue. So those are some of the things that you'd look for in red flags. Also, a baby that can't thoroughly drain a breast, or a baby that does a lot of clicking. Those are babies that need to be examined and may need more care. It's also really common after the baby's tongue tie is revised, generally about 3 to 5 days after, we like to recheck their motion with another exam, which is very similar to the one that was initially done, to see how much their range of motion has improved. Frequently, right after the laser revision is done, you'll put that baby to your breast and you'll be amazed at how much a full range of motion can really help that baby move milk and support your supply. If you have any questions, La Leche League of Central Kitsap Facebook page is a lovely group of moms and family members that have, most of them have nursed and all have great ideas and support. And finding a professional to examine the baby's tie if you saw some red flags in this. And you're welcome to leave comments if you want to show pictures of what some of your baby's tongue tie look like pre and post revision, so other parents can get a better idea. Thank you.